Venous thromboembolism, or VTE, is a disease that is manifested by deep vein thrombosis and/or pulmonary embolism. The disease process can start, for example, in the large vein of a leg with formation of a blood clot. This can be due to vessel wall injuries, which is a pathological increase in the coagulability of blood, or circulation deficits such as venous stasis. The resulting blood clot consists of mostly blood cells held loosely together by strands of fibrin. There is considerable risk of the blood clot breaking away and traveling in the bloodstream, through the heart and into the lungs, blocking a pulmonary artery. The consequence of pulmonary embolism. The affected area of the lung is no longer available for oxygenation of blood. This life-threatening outcome can be traced back to inappropriately triggered process of blood coagulation. The patients at risk for development of VTE usually have predisposing conditions to these three factors: endothelial injury, venous stasis, and hypercoagulability. These are called the Virchow's triad and are important to mention because it comprises of the etiology of venous thrombosis. Endothelial injury is damage to the endothelial surface and may be caused by trauma or external pressures. The endothelium of vessel wall plays an important role in clotting, and it produces a huge array of substances that are thought to prevent the disposition of thrombi or have local effects on coagulation and fibrinolysis. Venous stasis occurs when the valves are dysfunctional or muscles of extremities inactive. The coagulation process is made up of clotting and a fibrinolytic system. An imbalance in either of these systems will result in a tendency to bleed or tendency to clot. Patients prone to thrombosis will have either an inhibited fibrinolytic system or a hyperactive clotting system. In general medical, a variety of patients are admitted and usually present with multiple complex health conditions. It is therefore critical to shed light on some of the health conditions our specialty patient was experiencing, putting her at risk of VTE and eventually developing DVT. Obesity is an established risk factor for VTE. A large meta-analysis conducted by Matos et al. Concluded that waist circumference greater than 100 cm had links to metabolic syndrome, which is a cluster of risk factors for atherosclerosis. Greater amount of adipose tissue was linked with higher expression of tissue factor, type 1 plasminogen activator inhibitor, pro-inflammatory cytokines such as tumor necrosis factor alpha and interleukin 6, leading an obese person in a pro-inflammatory state, contributing to a procoagulant state. Visceral adipose tissue is believed to have harmful effects on vascular endothelial function. Hypertension is another risk factor. According to Zhang et al., it increases the risk by twofold. It is mediated by inflammatory state and hypercoagulability, leading a patient to a prothrombotic state. Hypertension causes endothelial dysfunction due to blood vessels exposed to high blood pressures. Endothelial dysfunction has been reported to be the initial step in atherosclerosis and represents overall functional changes which are characterized by vasospasm, coagulation abnormalities, and increased vascular proliferation. Such damage can lead to venous stasis and hypercoagulation state. The research study by Zhang et al. Yielded that 13.5% of patients with hypertension went on to developing some form of VTE. Cardiac conditions such as heart failure or AF put patients at a greater risk for VTE. AF increases risk by 8-fold. Abnormal hemostasis, including increased fibrin turnover and platelet activation, is well described in patients with AF, and an existence of this procoagulant state may promote development of thrombi in the deep veins. Moreover, hospitalized patients with heart failure are at an increased risk for VTE as well, and this is due to a variety of mechanisms including stasis of blood because of the dilatation of cardiac chambers, reduced myocardial contractility, decreased mobility, and increased intracardiac and central venous pressures. Endothelial damage related to malignancy can occur when neoplastic cells penetrate the vessel walls and cause initiation of the clotting cascade. Furthermore, the primary causes of hypercoagulability in malignancy is the production of procoagulants by tumor cells such as tissue factor. Once tissue factor is released, it activates coagulation factors 7 and 10, leading to thrombin generation, platelet activation, development of insoluble fibrin networks, and ultimately clot formation. Neoplastic cells also release vascular growth factors and proteins which lead to inhibition of fibrinolytic system, leading to an increased hypercoagulability. Moreover, malignant cells release plasminogen activator inhibitor type 1, which deactivates plasminogen, a component of the fibrinolytic system, leading to a decrease in fibrinolysis and continuation of coagulation. Last but not least, immobility is another risk factor for VTE, and it can lead to venous stasis, especially in the inactive extremities. Immobility, described by Yi et al., is prolonged bed rest, paralysis, restrictive activities such as fractures, inability to walk, and being chair-bound. In the research study, it was mentioned that 80% are likely to develop VTE if immobile for long periods whilst at the hospital, putting immobile patients with other comorbidities at a higher risk. The goals of treatment for DVT are to stop clot propagation and prevent clot recurrence. These goals usually are achieved with anticoagulation. Warfarin is an anticoagulant. As such, it disrupts the coagulation cascade to reduce frequency and extent of thrombus formation. It works by blocking vitamin K binding sites and inhibits the synthesis of clotting factor 7, 9, and 10, and inhibiting the synthesis of anticoagulant proteins. The onset and duration of warfarin on each of the clotting factor differs and thus requires close monitoring to achieve and maintain safe therapeutic levels for VTE prophylaxis. It has its advantages and disadvantages, and compared to new oral anticoagulants, warfarin is not the main drug choice for VTE prophylaxis. The new drugs used as prophylaxis include factor 10A inhibitors or direct thrombin inhibitors that work on the clotting cascade directly, and these drugs include apixaban, rivaroxaban, and dabigatran, and are the only 3 oral anticoagulants registered to use in Australia at the moment. Apixaban and rivaroxaban both work on factor 10A of the intrinsic pathway of the clotting cascade, and dabigatran, which is a direct thrombin inhibitor. In recent research, it is suggested that apixaban is more effective in preventing short-term VTE recurrence. One possible pharmacokinetic reason is that peak-to-trough ratios of rivaroxaban, which is dosed once daily, are much higher than peak-to-trough ratios of apixaban, which is dosed twice daily. On the other hand, enoxaparin, a low molecular weight heparin, selectively inactivates factor 10A of the intrinsic pathway and has been well studied and been used as a VTE prophylaxis quite often in hospitals. The dose is based on body weight and thus can be given once or twice daily to treat DVT. Our specialty patient was put on therapeutic 50 milligrams of enoxaparin twice daily. Some of the non-pharmacological interventions include early mobilization in an immobile patient. Patients should ambulate at least 3 times per day and change positions in bed frequently to prevent venous stasis and improve blood circulation. Secondly, graduated compression stockings, which provide sustained regressive pressure, prevent venous stasis, and increase blood flow velocity. Thirdly, sequential compression devices deliver varying amounts of compression to extremities, and in recent studies it was highlighted compression devices are less likely to cause vascular damage compared to compression stockings. And lastly, intravascular fibrillation device may be implemented in high-risk patients to prevent pulmonary embolisms. Each intervention must be assessed and applied to patient according to their condition.
Next part of our presentation, we will look to focus on the available treatments for said conditions and how they tie in specifically with VTE. We will first look into cancer treatment. Unfortunately, VTE can be a common side effect of patients suffering from cancer. Let's look specifically at lung cancer with our patient in mind. Venous thromboembolism, or VTE, is a common complication of cancerous malignancies, and epidemiological studies suggest that lung cancer belonged in the group of malignancies with the highest incident rate of VTE. Why is still not entirely known. However, studies have shown that by determining D-dimer levels in patients' bloods can be indicative of a poor outcome for patients suffering cancer or receiving treatment. This leads the patient and healthcare professionals to consider whether the treatment will be appropriate, considering the fitness of the patient and whether the outcome will be curative as opposed to having negative impacts on the patient's quality of life. Also considering that with treatment comes an increased risk of VTE. According to the National Collaborating Centre for Cancer, the main form of treatment with a curative intent includes surgery, chemotherapy, and radiotherapy. In the UK of 2017, The most common form of curative treatment was the surgical procedure lobectomy, where part of or all of the lung affected is removed. Being a surgical procedure, there is a heightened risk of VTE due to immobility, increased response of clotting factors in the blood, and a decreased volume of blood. According to Thomas and others, 1.6% of patients studied developed VTE post-discharge secondary to their lobectomy. This proves that post-discharge VTE prophylaxis is important. Radiotherapy is also considered a prime choice for cancer treatment, removing the risk associated with surgical procedures and reducing recovery time. Radiotherapy is a combination of electromagnetic waves and particle radiation designed to repair, repopulate, reassort, and reoxygenate cancerous cells. The ionized therapy disrupts atomic or molecular structures of the cell, therefore slowing and eventually inhibiting growth of the cancerous cells. The connection between VTE and radiotherapy is not widely known or researched. However, studies by Guy and others have hypothesized that the molecular structure damage to blood vessels increases the risk of bleeding. Therefore, they are at high risk of VTE. And finally, chemotherapy, providing similar outcomes in regard to survival rate, is often used in conjunction to surgery and radiotherapy. Chemotherapy is an aggressive form of treatment that inhibits growth of cells, which also causes resistance to anticoagulant activated protein C, largely increasing the risk of VTE. In fact, according to Ramos and others, every patient receiving chemotherapy treatment have a 10% risk of developing VTE. With the risks of VTE with surgery, radiotherapy and chemotherapy, it is important that patients are prescribed some form of anticoagulant to decrease the risk, as development of VTE has a negative impact on survivability. Risks of VTE within the first year of cancer treatment up to 1%, up to 1 year was 10%, 16% at 2 years, 25% at 5 years, increasing to 36% at 10 years. Several clinical trials conducted by Vital and others have signified efficacy of antithrombotic prophylaxis, specifically while receiving chemotherapy. Apixaban has been clinically proven to reduce VTE occurrences with cancer patients, however does have an increased risk of major bleeding. Therefore requires close monitoring from an appropriate health practitioner for prevention of complication. Now let's look at obesity. Due to the pressures and impact obesity can have on the human body, obesity causes generalized chronic inflammation. Inflammation markers are determined by levels of CRP. Obesity involves CRP markers usually sitting at equal to or greater than 10 mg per litre, while healthy ranges sit at equal to or less than 3 mg per litre. As a result, the obese person is at higher risk of developing VTE due to the chronic inflammation. Obesity does have a curative outcome by implementing a healthy diet, regular exercise, and making lifestyle choices. Obesity can be completely reversed by lowering a patient's body mass index or BMI. Dietitians utilize nutrition in order to provide a caloric deficit meal plan that is appropriate for the patient to follow, considering their favorite foods and providing alternatives that are more suitable. Physiotherapists devise care plans that are appropriate to an individual's physical capabilities and enhancing functional activity. Evanson and others described that a higher cardiorespiratory fitness was associated with a lower risk of incidences of VTE when combined with a caloric deficit meal plan. Bariatric surgeries, including gastric bypass and gastric sleeves, are also an option for obese patients. These surgeries are usually a last resort and are only used if diet and physiotherapy have failed to reduce a person's BMI. Curing obesity can have many positive effects on the body, including curing hypertension, diastolic dysfunction, type 2 diabetes, dyslipidemia, sleep-disordered breathing, and a lower risk of VTE. Fractures and incidence of VTE are closely related due to surgical intervention and immobility of the patient. However, medication and medical prophylaxis have been used to dramatically lower the chances of development of VTE while the patient is suffering from a fracture. Medications such as heparin and aspirin are known to control the risk of VTE and show a lower incident rates post-hip surgery. Clinicians need to balance the benefits of VTE prophylaxis against the risks, as bleeding can be a critical side effect, particularly post-surgery. Medications such as enoxaparin and rivaroxaban can be prescribed. However, their benefits are outweighed by the increased risk of bleeding.